once more. So thank you, Gian-Piero, for your introduction. And I think that I will repeat the previous report by Eduardo, but to look at this problem from the endoscope and microscope view. So nothing to disclosure. I think you know this very well-known picture, which describes the all possible approaches to the third ventricle. Of course, I'm not going to speak about all of these approaches. My task is compare the advantages and disadvantages of the microsurgical and endoscopical approach to the same region of the brain. So my report will be of three parts. The first part is devoted to the pure microsurgery. So, and if we speak about the transcallosal approach, so we have the special geometry of this place of the brain. So this is the bone flap, this is the dura incision, this is an incision in the corpus callosum, and foramen Monro. So this is the most posterior view to the third ventricle with the help of microscope. This is the most anterior view. So, and this part of the tumor may be removed under the vision of the microscope or during the open surgery. So, and this part may be partly invisible. So, nevertheless, such tumors of the third ventricle, gliomas, may be reached by the open microsurgery and with a good result, nearly gross total removal. The second most common tumor of the third ventricle in children is a craniopharyngioma, and the same with the open surgery. We may perform the gross total removal or subtotal, of course, if we keep in mind the possible damage to the diencephalic region. So in the majority of cases, we have to leave small remnants of the tumor in this region. So as Eduardo has told, the transcallosal approach has three possible entries, provide three possible entries to the ventricular system. This is through the right lateral ventricle, through the left lateral ventricle, and through the septum pellucidum. The next step is the three corridors to access the third ventricle. This is the intrafornical, through the choroidal fissure, and through the foramen Monro. To my mind, it provides the most natural corridor to the third ventricle. So, and these are the intraoperative pictures. If we go through foramen Monro, we shall keep in mind the risk of veins and columnar fornices damage. If we use the transfornical approach, this is the risk of the fornix damage. So, and let us look once more to the sagittal view. And this is the axis of the transcallosal approach, which goes through several levels. So the first level is the corpus callosum. The next level is foramen Monro. And the deeper level is the possible hole in the third ventricle floor if the extraventricular tumor destroy it. So, and if we plan the gross total removal, at the end of the surgery, we shall see basilar artery. All of these structures lie on the same axis. So, but in the majority of cases, it is not so easy to use the transcallosal approach to remove such tumors as shown on this slide. So if we use only the transcallosal approach, we shall remove this part of the tumor, and this part will remain unreachable. If we use the basal approaches, we shall remove the basal part of the tumor, and this part may be left invisible. So, but if we use the combined approaches, we may gain excellent results and perform the gross total removal. Other peculiarities I should outline for the transcallosal transfontanelle approach in the neonates. This is the fontanelle, And we have to separate and partly resect the edge of the frontal bone. And another peculiarity is that at this region, at the region of fontanelle, we have two layers, the dura and the periosteum, which are attached one to another very firmly. And it is very solid structure, and there is a risk of the CSF leakage. So, and let's once more look at the transcallosal approach, which is basically a keyhole one. So pay attention that it is about 1.5 centimeters long. We go between the hemispheres and reach the gyrus cingularis. Pay attention that it is not the corpus callosum. This is gyrus cingularis. We have to move apart, and then we shall see the pericallosal artery lying on the corpus callosum. And pay attention to the callosa marginal artery. Don't mix it with the pericallosal arteries. These are different arteries, and you should keep in mind it. When we move apart the pericallosal arteries, we see the white matter of the white tissue of the corpus callosum. And if we penetrate it, we shall see the foramen Monro. If we have performed everything correctly, it will lie on the same axis, on the same line as it was planned beforehand. Now we see the tumor bulging from the third ventricle into the lateral one. So the second part is the endoscope-assisted microsurgery. This is the combination of two methods. So the endoscope assistant is performed in the air environment. And here we can use the assistant endoscope, the microscope, and conventional micro instruments. Another implementation of this method is the keyhole neurosurgery, when we use assistant endoscope and the special paraendoscope instruments. So for this purpose, we use the special assisted endoscopes, which has an angled camera, the special device for the cleaning of the visual field, and of course the angled optics. So in the operating room, we have the monitor with the endoscope view, the monitor with the microscope view. And we may use the holding system in order to use both hands of a neurosurgeon to manipulate with the micro instruments. Let us look once more to the picture which I have shown you in the beginning of my speech. This was the situation with the microscope. But if we use on this step the endoscope, we can reach this part of the tumor and safely remove it. So let us look at this video. Of course, such a giant tumor was removed in the main part with the open microsurgery, but the part of the tumor which is hidden in the most anterior part of the third ventricle may be removed with the help of the endoscope assistance. So the white tissue in the upper part of the video window, this is the edge of foramen Monro. We are working inside the third ventricle in the most anterior part, using the angled optics, using the angled instruments, and thus we can safely remove this part of the tumor. So another idea is to use the endoscope for the, inspection of the most posterior part of the third ventricle. After the microsurgical removal, we can see the aqueductus cerebri, and on the other hand, we may inspect the most anterior part of the floor of the third ventricle in case if it is damaged by the intra-extraventricular tumor, we shall see the basilar artery and thus check the radicality and possible hemorrhage in this deepest part of the operating field. Another idea is to use the endoscope assistance in cases of the plexus papilloma of the third ventricle. In this case, we may inspect the operating field beforehand, before we use the microscope, in order to define the relation of the tumor to the third ventricle, to the walls of the third ventricle. Now you see foramen Monroe and the choroid plexus papilloma, which is located inside the third ventricle. We may even enter the third ventricle and check its relation to the floor and to the walls of the third ventricle. So another method is to use the supraorbital keyhole approach. And pay attention that it is really small. This is a skin incision. This is the size of the bone incision, and this is the size of the dura incision. And in this case, we use the only the endoscope so we use the microscope in the most beginning for the subfrontal approach. Then we insert the endoscope, and all other steps of the surgery is performed with the help of the endoscope. This is rather a rare case, the situation when we can use the suprachiasmal approach for the removal of the third ventricle tumor, because it was cystic and we can pull down the capsula from the third ventricle, but we perform it with the help of the endoscope, which is fixed. And in the end of the surgery, using the angled optics, we see the cavity of the third ventricle empty, the empty cavity, free from the tumor. Yes, this is the corpus mammillare, which you can see. And this is the septum, and this is the Lillenquist membrane. So, and you see the cosmetical result is rather good. And the last third part of my speech is the pure endoscopy. So, and pure endoscopy may be used to manage the cystic craniopharyngioma. Here you can see the huge multi-cystic craniopharyngioma. The patient was in a rather grave condition, and we decided to use the endoscope in order to connect all these cysts, to aspirate its contents, to reduce the size of all these cysts, and then to prepare the patient for the radiotherapy. So, and on this video, you see step by step when we penetrate, when we evacuate the contents of these cysts. But pay attention that during this procedure, you should keep in mind the balance between the irrigation and aspiration. We use the aspiration of these cysts in the water environment. So we shall keep in mind the balance of the intracranial pressure. So, and you see that step by step, we perforate all these cysts, and at last we made the connection with the third ventricle and with the lateral ventricles. And in the end of this procedure, we insert the tube. We insert the tube for a Maya reservoir. Here you see it's like a river in the ocean. So the the contents of the cyst, you see, is being irrigated, is being aspirated from the cyst. And in the end of this procedure, we used we inserted the tube, and thus finished this procedure. The catheter is also placed under the endoscopic view. And the last idea how to use the endoscope technologies for the treatment of the third ventricle tumors is to remove it with the ultrasound aspirator. For this purpose, you should use the GARB endoscope, the Soring endoscope ultrasound aspirator. This is the assembled device. It is very huge. I'd like to say we should use the water pump for irrigation. And but we have a very fine benefit because we may perform the irrigation from the water pump through the canal of endoscope and the suction through the ultrasound aspirator. That's why we shall have the clear view even in the case of the bleeding. But pay attention to keep the balance of irrigation and suction. And this is an example of the endoscopic removal of a cystic tumor of the third ventricle. We insert the ultrasound aspirator inside the Monroe, inside the third ventricle, and thus remove the cystic tumor of the third ventricle. Again, pay attention because the intracranial pressure may decrease very rapidly, but in the end of the procedure, this tumor was removed and we see the empty cavity of the third ventricle and aqueductus cerebri. So to conclude, where has technology taken us? Endoscopic or open surgery? No, it's combination. And it makes possible to perform the keyhole approaches, to perform the endoscope assistance, and thus to operate younger children with better illumination, with higher radicality and more safe. Thank you.
Great. Thank you, Professor. That was amazing. It's so wonderful that we could start with molecular biology and end with mastery of microsurgery. I feel like we've completed the whole trip, so that was a perfect way to end. Are there any questions? There was a question from the last talk that kind of spilled over about that so far the posterior interhemispheric approach to the third ventricle has not been mentioned so much. Perhaps you and the prior speaker could address that to the audience.
Sorry, what?
The audience was asking, they were asking what you thought of the posterior interhemispheric approach to the third ventricle.
Posterior, yeah, sorry. No, you see, if, to my mind, if a tumor is located in the posterior part of the third ventricle, it is really more useful to use the supraorbital approach, as Eduardo has showed us, or the approach, the supracerebellar approach, because to my mind, the majority of the tumors located in the posterior part of the third ventricle are the pineal tumors, and that's why we more safely we may use the supracerebellar approaches to this part of the third ventricle.
I agree with the Dr. Sergey. Dr. Sergey, congratulations for your lecture. Very complete and nice cases. And I agree. Usually, the ones that are located at the posterior part of the third ventricle, they usually arise from the posterior wall. That's the pineal region. I would be more comfortable going supracerebellar. There have been discussions about how posterior you can go interforniceal, and some people will say that there is a commissural fibers there, which I agree. And if you cut commissural fibers, it's called the hippocampal commissural fibers or interforniceal fibers. If you cut them too posteriorly, you will possibly harm the connection between both limbic systems, and the patient can have functional deficits as well. So I would be more comfortable going supracerebellar.
And I may add that you should plan the transcallosal approach for every patient. I have shown you the line, the axis of the transcallosal approach, but it may vary. The entry point of the transcallosal approach may vary. It depends on the proper localization of the tumor. If the tumor is localized more posteriorly, you have the entry point more anteriorly on the skull, and vice versa.